Hey, everybody. Welcome back to another episode of the Ardent Wife podcast. And today we have our special guest back with us, Dr. Kerocak, Dr. K, and of course, Tiffany and Dee are with us today as well. And today we want to talk about a health issue that affects women, right? Because what happens in our bodies affects us as women, which then it affects our relationship. And so we do think it's really important for us to be educated and learn about what's happening in our physical bodies so that we can be well, because we know that that will help our homes, our families, and our marriages. So thank you, everyone, for being here. And Dr. K, we're so glad you're here.
It's always a pleasure being with you, ladies. Thank you.
It's a lot of fun. And so today we want to unpack PCOS. And so maybe we just start off by saying, what is PCOS? And unpack that for us and we'll get started.
All right. So PCOS is short for polycystic ovarian syndrome. And realistically, what's happening is that a woman's ovary is designed to create eggs. And instead of having eggs, what happens is that these cysts form. And so why does that happen? And so normally there's this natural rhythm, in the 28-day cycle of the menstrual cycle of a woman, there's this natural rhythm where follicular cells will make an egg and release that egg in terms of preparation for fertilization. But sometimes things go wrong and the follicular cells do not make an egg and they make a cyst instead. And so you have a period or menstrual cycle where there's no egg, what's called an anovulatory cycle. And the egg and the products of that egg actually affect and produce some of these hormones. So when the egg is not made, there's a shift in the hormones. Lastly, if there is a cyst, the cyst gets filled in with a different type of cell called thecal cells. And thecal cells release testosterone, the masculine hormone. And so there's this very strange androgenation or sort of masculine characteristics that occurs with polycystic ovarian syndrome, which trickles down into the next cycle, which leads to an anovulatory cycle, which starts the process all over again.
That sounds complicated, but how do you even know that's happening?
Doctor on TV.
But how do you know that's happening? How is PCOS? How is it diagnosed, and how do you know you're having a cycle without releasing an egg?
So it gets missed a fair amount of times. So how do we know it's getting diagnosed? Sometimes it doesn't get diagnosed. So usually it's one of two complaints, or sometimes both complaints that occur in the visit. A woman comes in and says, I'm having irregular menstrual cycles. I'm missing my period. I'm having longer periods. I'm having shorter periods. So something is not rhythmic in the menstrual cycle. That's somewhat of a telltale sign that something's off. Or these secondary masculine characteristics or androgenation or androgens, excess androgens. So you get hair where you don't want hair. You change aspects of skin, oily skin, acne. And so these changes start occurring in regards to excess androgens. Because of this as well, you get insulin or insulin resistance changes. So you gain weight and you have changes to your sugar levels and your cholesterol levels. So abnormal menstrual cycles, changes in androgens or masculine hormones, and then metabolic syndrome or insulin resistance occurs. So those three things, or one of those three things, occurs in terms of the visit.
Do we know why? Why does PCOS occur? Is there an answer to that?
There's about 4 to 5 different theories as to how it works. Some of which are mainstream and some of which are kind of in my field, the functional field. And so some of it is what we eat, how we manage our stress, our sleep-wake cycle, and some of it is just changes in hormones as a woman ages. So as much as the big changes occur during puberty, obviously, you're going from a girl to a woman, but there are changes in hormonal levels during womanhood as well. And if things get thrown off once, that can create a cascade. The other theories, which are a little bit tougher to prove, is exposures to estrogen-like chemicals. So if I'm reheating my food in plastic containers, or I'm working around certain chemicals that look like estrogens or thyroid abnormalities, that can create monkey wrenches or chemical disruptions in the natural pathways. So there's a lot of lifestyle components that occur. There's some hormonal changes that occur, and there might be environmental components that occur.
Out of the four, I guess, which one's more evidence-based than just theory?
The one that is really mainstream is the hormonal abnormalities, and that's usually the component of treatment. But I find that many of the women that come to see me with PCOS are very frustrated with their diagnosis and then only receiving birth control pills as the way to treat it. So I have polycystic ovarian syndrome, I have irregular menstrual cycles. Here's a package of birth control pills. You just take that, will regulate your cycle. Well, what if I want to get pregnant? Well, we'll come to that when it happens. Well, how do I get rid of the weight? Well, we'll worry about that later. Well, how do I get rid of this hair and this acne? Oh, we'll worry about that later. So let's just regulate your menstrual cycle. Whereas getting to the bottom of it is much more interesting. From my perspective, getting to the bottom of it is usually somewhat listening to the story, trying to understand the lifestyle components that are vulnerable, and then getting the appropriate laboratory analysis to find out what's too high, too low, or just right.
Mm-hmm. And as a patient advocate, what labs will we request from our doctors if we want to go down that route?
So for me, the things that are most helpful are the pituitary hormones that regulate the cycle, specifically luteinizing hormone, or LH, and follicular stimulating hormone, FSH. There's a theory that if your LH is 2.5 times your FSH, that's an indicator of PCOS. So that's a marker, right? Checking estrogen and progesterone and testosterone, but specifically at days 18 through 25 in the menstrual cycle. So if you do it in other parts of the menstrual cycle, they're too close together or they're not there at all, so it's not helpful. But in the luteal phase, after the component of the egg being released, progesterone should be high, estrogen should be at least climbing, and so they're different. If you don't have the egg, if you have an anovulatory cycle, you don't ovulate, you don't make the progesterone's low, and so that's indicative of the abnormality. Thyroid is something worth doing because thyroid can throw things off. Insulin is worth doing because, again, insulin being high, which is often missed, is associated with this. And then a little bit more elaborate, I would probably wait for the laboratory analysis, is actually doing an ultrasound, an intrauterine or a pelvic ultrasound, to see if there are cysts on the ovary itself, because that's one of the criteria.
I thank you for that, because when we were talking earlier, you're saying sometimes doctors, just because of how patient care is, they just don't have the time to go through all of these things in a 10-minute visit. So if as a woman we come to our doctor with questions like this, it might allow it to kind of expedite. Or
it's helpful, and it's complicated because when a young woman comes to their physician and tells them, I'm just having irregular cycles, it's like, well, just wait it out. Let's see if it becomes regular, and then it can get missed, and it can go on for years being missed. And then, unfortunately, like many things, the longer you wait for the diagnosis, the more complications and more problems you have long term.
Yeah.
So what are some of the lifestyle things that people can do? Because there's some things that are in our control and there's some things that are not. So maybe talk a little, because even when I ask that question, I'm making assumptions. So what is in our control of what we can do, right? And what is not?
So one of the things I find, at least in my personal practice, but I don't have the literature to back it up, it's just I have the biochemistry to back it up, is that if there's an overproduction of cortisol in a woman's body, she'll have an underproduction of progesterone, which will make her susceptible to an anovulatory cycle. So if she has high stress or poor sleep, or overextension in her schedule, she will then overproduce cortisol. Now, cortisol biochemically is made from progesterone, and progesterone is important for shedding of the lining. So if you're using your progesterone to make cortisol instead of shed your lining, you can get into problems. And again, we have women sleep 8 hours and do stress management techniques, which I understand it's easier said than done. I totally understand. So sleep management, 8 hours, and stress management technique. But then, if I have a single mother of two who's working 2 jobs to support her family, like, what do I tell her? You got to get 8 hours with an infant, and I've got 2 jobs, and like, what do I do? And There are some botanicals and some management components to help with the cortisol, but really sleep and stress management. Food plays a big part of this. So if you have a lot more processed food and a lot more simple foods as compared to, believe it, fruits and vegetables, that can create aspects of bowel movement changes. Right. So when we have higher levels of fiber in our diet, we have healthier bowel movements. Bowel movements are how we get rid of estrogen. Even as men, that's how we get rid of estrogen. So we don't have as much excess estrogen, which makes us less susceptible to polycystic ovarian syndrome. So putting fruits and vegetables, higher levels of fruits and vegetables in the dietary plan can actually help us get rid of estrogen and estrogen-like substances, so that way we have more of a natural cycle in terms of the menstrual cycle. And then physical activity, exercise. So as you gain more fat cells produce estrogen. As you gain more muscle cells do not produce estrogen. So changing your body composition through resistance training can actually help with polycystic ovarian syndrome too.
Dr. K, come on, we got to eat well, exercise, move, drink water, again,
sleep 8 hours.
Fill me up with some of that C-maglutide.
I know it's this.
that.
It comes back to that, right? It comes back to that over and over when it comes to most diseases, when it comes to, I mean, so many things, and it's so simple. And
Right.
My theory is God gave us a wellness plan in the first 7 days of creation.
Well, yeah, that's exactly what I based my clinic on. So that's absolutely right.
Yeah.
He taught us the circadian rhythm. He taught us our food. He taught us to actually work. And it was resistance training work because they were farmers, you know. Right? So, and he brought animals to actually help us. And so it's important that we develop a community, you know. So there's all these different components. So
right. And I think, I think our culture makes being healthy about vanity, like it's all about the way you look, but it's so much more, it's so much bigger than the way you look.
Right.
Obviously, because our body is in dis-ease, which is causing disease because we're not living a healthy lifestyle.
And to go back to the idea about the vanity component, I think that has been disproportionately ridiculed at this point in time. I think it's equal in men and women. I think the standards of beauty for women and men is unachievable at this point in time, and yet the movement of body acceptance is ridiculous just as well. Yeah. So it's just like, okay, so now it's just like, well, you can't just do whatever you want and not have consequences. Yeah. And equally, you can't be a size 0 and think that that's going to be like sustainable. So, so there's got to be this aspect of rhythm and practicality. Yeah. And I probably am such a broken record, but it's not that hard. The problem is it has to be consistent. It really has to be consistent. People ask me, and I stole this from a YouTube video. So it's just like, how do you lose a lot of weight? Well, losing a lot of weight is like losing a little bit of weight, just longer.
What ultimately is it causes change of what you're doing now to something that's optimal for your body. We don't like change. Like that's something that's uncomfortable. It's challenging. It's foreign. And especially when you begin, right? Like the little bit of weight for longer. But once you start and you consistently do it, it's no longer a change. It's a lifestyle. And so I think it's
there is this aspect of delayed gratification that I think is challenging for most people. So it's like, okay, well, if I deny myself, if I sacrifice something now, I may get reward later. And this is true not even in just the weight loss component, which is associated with the PCOS. If I delay my party lifestyle in high school and actually work in my academics, I might get a better career. And if I spend time investing in my spouse, I might have a better marriage later on. So there's you will sacrifice and you will suffer either in the short term or the long term. You just have to choose which sacrifice you want to make.
Yeah, right. I keep thinking about the idea, and not to be harsh, but we will reap what we sow, right? But with God, there's a blessing on that other side. Like I just want to remind people, like there's a blessing on the other side. It's hard. It's hard. I'm having to give up a few things myself right now. And at every turn, I'm like, oh, there, oh, wait, oh, nope, I'm not doing that, And so, but there is a blessing on the other side. We will, reap a harvest if you do not give up, but you have to do the work.
Yeah. And sometimes harvests take a long time, and and sometimes they don't come. The first season they don't come, and you have to be okay with that.
And then I think it's this mindset sometimes too that God is going to do the work for it. Like, I don't have to do anything. Like, no, it's a partnership. You just don't, like, God, I need to, and then you sit back and do nothing. Like,
There's a beautiful aspect about, like, God does determine outcomes. And I'm so thankful for grace, because I have sown seeds that I do not want to reap, and God in His grace killed that harvest for me, at least most of the time, But I always hold to the idea about, like, the farmer goes out, he plows the field, he plants the seeds, and he prays for rain. Yeah. So, like, so there is this partnership component. Like, you do have to do the work. God determines the outcomes. But if you don't show up and do the work, the outcome can't occur. They're going down the idea. So, like, those are the lifestyle components. So in more, so, like, what happens when my lifestyle components are all lined up and things are still, I've had PCOS for a significant amount of time, and lifestyle is either going to take too much effort or too long, or it doesn't make an impact. Then we try to go after the specific abnormalities within the dynamic of polycystic ovarian syndrome. So is it an estrogen problem? Is it a progesterone problem? Is it an insulin problem? More than 50% of the time, and probably close to 80% of the time, insulin plays a big role in this. So we may use medicines to alter women's insulin to try and give them more of a fighting chance in regards to getting their insulin back to normal. And on the other side, if it is a progesterone estrogen component, we may use medicines to alter the progesterone and the estrogen. Most of the time, it's birth control pills. Sometimes what I'll do is I'll put progesterone in at the right time. So progesterone should be elevated at that 18 to 25. Sometimes with difficult PCOS, I'll put the progesterone in at days 18 to 25. I'll do that for like 2 or 3 cycles. And then it kind of, in a strange way, primes the woman's pump back to normal menstrual cycles. Her lining sheds, she gets ready for an egg, her lining sheds, her gets ready for an egg, and then you pull the progesterone away and she's back on cycle. You correct the abnormalities if the lifestyles aren't enough.
Now, what about the woman who says, I'm just over it and I just take it all out? Take the uterus, take the eggs, just take it all. Then what would you say to that woman?
So realistically, it's really funny because our sermon series today was the idea of I'm just done, and it's like, well, what does that mean? I'm just done. So it's like, well, what I'm going to do is I'm going to take all the parts, I'm going to take all the working parts out that are affecting these problems. And so I would say, well, I would want to know how old the woman is. So it's just like, okay, make sure that you understand that your likelihood for children moving forward is 0. So are you sure that this is the decision you want to make? You don't want children. So that we have to talk about. Second, do we take out just the uterus, which is going to be and leave the ovaries behind, in which case you haven't really solved any problems. Because remember, insulin is a big problem, weight gain, excess androgen is a problem, oily skin and hair. So if I just take the uterus out, now I don't have irregular periods, but I still have the organs that are going to disrupt the hormones. So it's like, well, we're not really solving anything by taking the uterus out except symptoms of the menstrual cycle. Right. And then if we go to the extreme and we say, okay, well, I'm going to take out your uterus and your ovaries. Well, guess what? Estrogen's actually kind of important for femininity, for bones, for longevity and health. And it's like, so what you're doing is I'm catapulting you into menopause instead of PCOS. So now we've got a new system of problems associated with menopause. So I would say, well, I feel like many things that, like the fig tree that doesn't produce fruit, it's like, give it 1 year. It's just, let's give it a year. Let's give it a season and see, Right. The other thing is, which is is that when you start looking into it, there's these components of wedge resection. So it's the idea of like, I'm going to carve out a piece of the ovary, and then when the new ovary grows back, it'll come back normal. It's a very interesting idea. And then there is bariatric surgery is used to treat PCOS. But again, it's sort of a roundabout way of looking at how we're going to handle the problem. It's like, it's kind of extreme, but I understand that some individuals will need to have the extreme approaches.
Gotcha.
And so then how would you say for a spouse to support, and this is just in women, PCOS is just in women, so how would the husband support the wife in what would be helpful?
So speaking as a man, I will tell you that one of the largest problems of men is solving problems more than listening to the story. And so the advice I tend to give to the spouse, to the husband, is this is more complicated than it seems. Mm-hmm. And eating salad and going to and having your wife go to the gym with you may not actually solve the problem. So what I find more often than not in men is just like, well, if she just did this or she just did that, it would go away. And I'm like, you're not helping the problem at all. It's like, yes, if we did incorporate the components of the lifestyle, then some of these could actually go away. And then I usually, what's nice is being 56, most of the time I'm the paternal figure in the room. So it gets to be kind of nice. I'll tap the husband on the knee and say, let me give you a little bit of husbandry advice. So phrase it differently. I said, phrase it differently. Not like, oh, she should do this, she should do this. I said, you're going to spend time in the doghouse doing that. This is how you're going to say it. You're going to say, how can I help you achieve this? Oh, look at all the faces. Like, how can I help you achieve this? What do you need me to do to make this easier for you? I said, be part of the problem solving committee, not the problem identifying committee. It's just like, it's right. So then if you say, well, do you need me to pack your lunches? Do you need me to take care of the kids? What is it that I can do to make it easier for you to get these lifestyle things in? So I try to advise the spouse that, one, it's more complicated than you think it is. And two, phrase your approach differently. How can you help the situation? Not let me show you what's wrong.
Yeah.
That advice right there that's just life advice.
Not just with PCOS.
Life position, gentlemen, let me tell you. I was not born that way. That took me 10 years to learn.
Bookmark that part right there. Just so you can, I just wanted you to hear this one part.
So is there anything about this that, I mean, we like put like a small little, that's a small little bit of information about it, but is there something we haven't asked you that you think is important for people to know if they're thinking they have PCOS or they're struggling with it, or they're in the process of it and kind of at a place where Tiffany said, ready to give up? What, or is there just something you think is important for people to know and understand?
I think going to see your providers or your OBGYN sooner than later is probably beneficial. So like if you start seeing skin components or menstrual cycle components, like those are the beginning telltale signs. And the longer you stay in anovulatory cycles, the harder it is to treat. Because remember, as the cysts form, they get this fibrous material to fill it in. And so the more fibers you have, the harder it is. The more androgens you have, the more insulin you have. And then, after you've gained, it's easier to take care of it when you've gained 5 pounds as compared to 40 pounds, because there's a lot of hormonal feedback systems that are going on by that time. So after if you have a problem, you're in 1 month and it goes into the second month, don't say, I got so many things going on, I'll just wait. And then 6-7 months go by, which it can happen because you just get busy. You've got to take care of kids. You're doing your job. And it's like, no, I think that going sooner than later, because it does get missed a lot. And then second is don't take the answer of, well, we'll just put you on birth control pills or we'll watch it for a month. I think that your provider really owes it to you to do some sort of intervention and exploration as to sort of like, no, this is me, this is my body. I really want to know what's going on. Yeah. Show me more than just giving me a pill or having me wait for another month.
Mm-hmm. Yeah. Is there an age that this typically comes up? Is there an age range that this?
That's very interesting. So I was trying to read into that because there is this idea that you might have it in menopause, but it's very difficult to diagnose. And the irregularities in menarche, the early stages of menstrual cycles, it's so abnormal, it's very difficult to say. So if I had to pinpoint, I would say somewhere between 20 and 40 is kind of like the window where it is most likely to occur, but it could occur anywhere. It could occur at any age where there's a menstrual cycle. But 20 to 40 is what I tend to see as the most common. age window.
I'm curious if certain type of birth control contraceptives also, like IUD, Depo-Provera, like those different types, and PCOS, are they connected in any way?
So PCOS tends to be a problem, again, related to anovulatory cycles.
Right.
So if I'm going to put in a device that's going to not make me ovulate, but also not make me form eggs, usually doesn't. It usually doesn't. So if I have a progesterone one where I'm constantly having this sensation that I'm pregnant, like, does pregnancy lead to PCOS? Not really. So otherwise, women who had more children would have more PCOS than women who don't. And so there's not that correlation. So it's like, well, if I bring in progesterone, does it affect it? Probably not. I'm not a big fan of the irritant type IUDs, like the ones that are made out of copper that just irritate your lining all the time. I think they create excess cortisol and excess dynamics that might lead to some problems in regards to that. And then the birth control pill formation is usually a combination of progesterone and estrogen together. And so that usually doesn't lead to greater aspects of PCOS. It's one of these things where PCOS to me even is sort of a chicken and egg phenomenon. It's hard to say, well, what came first? The PCOS, the stress, the weight, what really came first to cause this? And then usually by the time they get to the provider, they've been in it for 3 or 4 months. So, I mean, it's a terrible example. Let's imagine that you have an autoimmune skin disease and it's itchy, and you scratch it and then it gets infected and now the skin is infected. And like, well, what came first? It's like, well, now at this stage of the game, there's so many things going on. We have to just take care of it. We can't really figure out what happened first. So I find PCOS is usually they go to the physician too late, and then it's a chicken and egg phenomenon where it's like, you have asked questions about chemical exposures, how many children you have, your birth control. You so try to tease out what came first, but at the end of the day, you treat the overweight individual versus the underweight individual a little bit different. You treat the woman with excess androgen a little bit different than the woman with less androgen. So you try to treat the woman that's in front of you as the individual. So.
Yeah. Is there a specific diet that is better for PC? I've heard low sugar and higher protein. Is that correct?
So it's hard. So the classic one, I don't really do this except in extreme. The classic one is honestly bordering on plant-based or almost vegan type diets. The Daniel fast type things where you're just using plants for a time period. So I have on occasion had women do a 28-day cycle of mostly plants, and fish is their only protein. It's an extreme food plan, but it's a very high fiber, high phytonutrient, estrogen modulator type component, and I would not want to do it for more than a month. But I pulled women out of PCOS with this somewhat extreme plan. I think as a backup plan, ketogenic diets have been shown to help with PCOS, and really strict Mediterranean diets have been shown to help with PCOS.
Okay.
So you can imagine, it's going to be calorie restrictions and proteins, but I think fiber and phytonutrients from plants have got to be a big part of it, and lowering insulin's got to be a big part of it.
Okay, great. Well, that's really helpful.
I think I would tell women out there to just pursue the diagnosis a little bit sooner than they think. Because again, it can get missed for several months, and that if something is not right with your body, you should speak up about it. I think the earlier you catch it, the better off you are, and then ultimately having these lifestyle pillars in place is going to be the best prevention of it.
That's awesome. Great. And I think that's great advice to our listeners. You guys take the time to care for yourself. Take the time. If something is wrong, I think as women, we are caretakers and we can often take care of our families and other things. So pay attention, get to the doctor, get your annual physical, get your mammograms, all those things. Take the time so that you can show up healthy and well. So thank you again, Dr. K, and thank you guys for our listeners tuning in, and we will see you on the next episode.